This is the last section of the renal unit. Renal failure is going to cover acute and chronic renal failure, which we'll go over one then the other. And then we will talk about all of the different body changes that happen, and you'll find that every single body system is affected by renal failure. Then after that, we will talk about goals of treatment, we'll talk dialysis, and also a little transplant. So when we're talking about acute renal failure, typically we are looking at three different origins for renal failure: pre-renal, intra-renal, and post-renal. Pre-renal almost always deals with something vascular, so either a stricture or something that's occurring prior to the blood getting into the kidney, or something that decreases blood flow just all the way around, something that causes hypovolemia. So pre-renal causes decreased blood flow to the kidney. If the patient cannot attain and maintain a blood pressure of at least 70, then they're not going to have any glomerular filtration at all. I'm not talking normal, I'm talking any at all. If their BP keeps fluctuating below it and can't remain at 70 or above, that's a recipe for one of the ways to cause acute renal failure. Of course, one of the ways to cause that is to have low blood volume. So if the patient's been in an accident and they're in shock by definition is, marked hypotension. Trauma, any kind of hemorrhage, anything that can cause a decreased blood volume can cause this type of renal failure, or if there is a stricture involving the blood flow going into the kidney. The next type is intrarenal, and now we're talking about things going wrong inside the kidney itself. So one of the things that can make that happen is a nephrotoxic agent. Say, for instance, an antibiotic, gentamicin. Gentamicin is well known for being highly nephrotoxic. So when a patient's on gent, we're always doing peak and trough levels to make sure that we're not harming or having too high of a level and harming the kidneys. Heavy metals like mercury and lead can also be nephrotoxic agents. Cleaning compounds like usually industrial kind of cleaners, pesticides, and my personal favorite, poisonous mushrooms. Because every spring in the Ozarks, people go out into the woods and think they know what they're hunting for, and some people do and some people don't. And those people tend to ingest some type of poisonous mushroom that ends up nailing the kidneys, and then they're in the MICU for a couple of weeks. So those are our nephrotoxic agents. Infections or other disorders that can cause intrarenal renal failure include pyelo. If you have pyelo often enough, it goes chronic. You can start damaging the tissue because of the massive inflammation. Glomerulonephritis, because glomerulonephritis actually happens in the nephron itself, whereas pyelo's in the renal pelvis. Glomerulonephritis is in the nephron, obviously in the glomerulus. So that can definitely impact the ability of the capillary loop to do what it's supposed to do. Therefore, it could cause renal damage. PKD, that's the polycystic kidney disease, the one where it's a genetic disease that replaces normal renal tissue with cysts. And then renal TB. We always think of TB as a lung thing, but when TB is permitted to go systemic in the body, it has an affinity for renal tissue and it likes to destroy it. And then anything that causes an occlusion of the intrarenal arteries. So here we are with blood flow again, but instead of being pre-renal, this is within the kidney. So narrowing of the renal arteries because of strictures or atherosclerosis, those fat build up. Patients with hypertension put a lot of pressure on their vasculature. That can cause arteriosclerosis. And then your patients with diabetes, of course, they make more atherosclerosis. And when they're diabetics, kind of the combination together, we kind of call that nephrosclerosis. So bottom line, we have any type of issue that can impact perfusion inside the kidney. That's going to contribute to this intrarenal causes of intrarenal or acute renal failure. And finally is post-renal. This is actually the least common, but when obstructions beyond the kidney cause reflux, so if you have a ureteral stone that's blocking the ureter, and then that ureter won't drain, so the urine pushes back into the renal pelvis, and then it causes hydronephrosis. So kidney stones, ureteral stones, they can both cause hydronephrosis, so can BPH. All of those things can be fixed surgically if we have the right type of intervention. So on pre-renal, you probably need some kind of vascular surgeon or somebody who's able to deal with trauma and shock, because that's the situation with the patient typically. Intrarenal, you need a nephrologist, somebody who understands the inner workings of the kidney and can manage all of the different problems that are associated with that. With post-renal, you need a urologist, because they're going to need to probably do a surgical intervention to prevent an obstruction and then restore urine flow so that the kidneys are no longer being damaged. Who's at risk for renal failure? Anybody having major surgery or trauma, those taking nephrotoxic agents, and of course your geriatric patients, because let's face it, they have fewer nephrons to begin with. So we'll talk acute renal failure first. It has 4 stages: onset, oliguric stage, diuretic stage, and recovery. The thing about onset is we rarely ever find it when they're in it. Onset something when they're in oliguric stage, we look back and go, oh, there's where that started, because none of these symptoms are definitive enough. It only lasts 1 to 3 days. Their BUN and creat may be at the high end of normal or just a little bit elevated, but it may be so mild that it really doesn't throw up any red flags. Their urine output's probably going to be normal to slightly decreased, so again, still not red flags. And in this situation, all we're trying to do is restore function and prevent further damage. But again, we usually don't even figure out when it all truly started until they're in the next phase. The next stage is the oliguric stage. This follows onset and can last up to 14 days. And kind of the primary or cardinal symptom that we're looking for here is a urinary output right at 400 cc's per day. I'm not making that up. I mean, it could be 390, it could be 410, but it's going to be right around 400 cc's per day. The other main issue that you'll see is if they're only putting out 400 a day, you'd expect that urine to look dark and concentrated and kind of nasty. Nope. That urine is going to look beautiful, straw yellow. It's not going to, look bad at all. That's because of something called azotemia. Azotemia is a result of the fact that the first function lost in renal failure is the ability to concentrate urine. It's also the last function gained. So this person should be putting out nasty looking urine if they're only putting out 400 a day, but they're putting out beautiful urine. Well, you can imagine if they're only putting out 400 a day, they're becoming hypervolemic, okay? So they're holding on to more fluid in the body. The result of that is going to be, since we have azotemia and a low specific gravity, we're going to have our urine osmolarity, or concentration, go down. That's why the urine looks pretty and clear and nice straw colored. But the serum osmolarity, the crap that they're hanging on to, the concentration in their serum, is going to go up. That's why they're getting sicker and sicker, because they're holding on to all of those waste products. And then the final part is the kidney really just, it's like it's having backwards day. Things that it should be getting rid of, it hangs on to. Things that it should hang on to, it gets rid of. It should hang on to calcium and bicarb, but nope. It's going to let, in that little 400 cc bit of urine, there'll be calcium and bicarb in that. Whereas things it should be getting rid of, like BUN, creatinine, potassium, and phosphorus, nope, it's going to hang on to those. And hanging on to that potassium is actually life-threatening, and we'll talk about that momentarily. The next stage is the diuretic stage. This begins when the urinary output actually exceeds 400 a day. So you might have a day where they're up over 500, and then the next day they're up over 900. Then maybe they hit 1500. There will be a time, potentially, when their urinary output could actually rise above 4 liters per day. But here's the rub. Remember I said that the first function lost was the ability to concentrate urine, and it was the last function gained? Well, the kidney's not completely back to normal yet. So even though they're putting out all of this urine, and that is helping their hypervolemia situation, they're not excreting very many wastes. And so they're not going to get markedly better until later in this diuretic stage, when we start seeing that the BUN and creatinine start heading back down, and the potassium heads back down, and the phosphate heads back down, and then we begin to retain calcium and bicarb. That's what actually signifies the return, or at least the beginning of the return of renal functioning. The final stage is the recovery stage, and this can last anywhere from 1 month to a year. It could take up to a full year for the kidney to completely bring everything back to normal. That means get all of the serum electrolytes back in normal range, the BUN, the creat, all of it. In most cases, that will happen sometime within that year. But if somebody has had multiple bouts of acute renal failure, or they've had something go on where they've had some extraordinary damage, then it's possible that complete recovery does not occur. If complete recovery does not occur, then we will have a measurable loss of renal function. That tends to send them closer to what we call renal insufficiency. So let me give you an idea of what I mean. When a patient hits 50% loss of function, we kind of say they're going into renal insufficiency. And by that we just mean, you're not getting any better at that point. Once you've lost 50%, the likelihood that you can go back and regain any of that is pretty slim. So from 50 to 80, they're kind of going into renal insufficiency. When they hit 80, they are in full-blown renal insufficiency. So that's 80% loss of function. Now they can live this way unless other problems are placing additional burdens on the kidney, and the reason they can is because of something called organ reserve, which we'll discuss momentarily. So now we're switching gears to chronic renal failure. Unlike acute renal failure, chronic renal failure is a gradual onset. It's insidious. This takes months and months, even years, to even see any measurable signs or symptoms. But all that time, they're going to have progressive, irreversible damage of the kidney. So this is going to be something that's going to be going on for a long time. When the patient hits the point at which they have 90 to 95% loss of function, that's when we give them the diagnosis of chronic renal failure. And of course, at that point, azotemia is going to be a permanent fixture. I said before, it's the last function gained. At this point, the kidney is never going to resume all of its proper functioning. So azotemia is going to be a constant companion. That means even if this patient only puts out 700 or 800 cc's in a whole day, it's still going to look very clear yellow. It's going to look, like that perfect 1.010. The other term I need you to become familiar with is uremia. Uremia is an older term for chronic renal failure because of the saturation of urea in the blood. So I just didn't want you to not, actually know what that means, because that is a term that is sometimes used to describe end-stage renal disease or chronic renal failure. I've been discussing azotemia, but just wanted to start, we're kind of going to go through all of the different things that happen throughout all the body systems with renal failure. And since azotemia is the first function lost, we're going to talk about it again. It is the inability to concentrate urine. Basically, what you will see is that 1.010 beautiful urine, even when they're not putting out very much. What that means is very little is in the urine, so the serum is going to continue to hold on to creatinine and BUN, even if they produce a large quantity of urine, even if they can produce, a liter or two, it doesn't matter. The serum is going to hang on to that extra because the kidney won't put it out. As the disease progresses, however, urinary output will continue to decrease until that chronic renal failure patient will reach a point where little to no urine is produced. Like they literally could have no urine in a whole day. So serum creatinine, we mentioned before, is the best indicator of kidney function. That's not to say that we ignore BUN. BUN is still valid, but other things can tamper with BUN numbers, whereas with creatinine, that's really going to show us what's going on with the kidney. So knowing the normal range of 0.5 to 1.5 is something that I want you to have in your brain. And you can utilize that to help you figure out what's going on with your patient in the clinical setting. Because a creat, which is twice the normal, or 3, represents 50% loss of function. So any patient that's got a creat of 3 or above, we know that they are going into renal insufficiency. They're heading that direction. A creatinine which is 10 times the normal, or 15, that represents 90% loss of function and would likely result in the diagnosis of chronic renal failure or end-stage renal disease or uremia. Now, why is this all these percentages, or why are they important? Well, because we have a property called organ reserve. Our kidneys actually only utilize 20% of our nephrons on any given day. 20%. That means we have 80% organ reserve. The kidneys have a lot of extra. But when your patient's in renal insufficiency and then they're going into potentially renal failure, they're getting up to that 80% and then going beyond. Up to 80%, the kidneys can still function, but the minute we go to that 81%, now we are not functioning on as many nephrons as we need. And that's why we're going to see, those changes. The other thing that will happen is if a patient is young and healthy and something happens and they lose a kidney, maybe like a motorcycle accident or some kind of motor vehicle accident, or maybe they've given it for donation, the other kidney will actually hypertrophy and increase its function. So if you're young and healthy and the kidney's healthy, the kidney can hypertrophy and increase its function if needed. However, when the patient has kidneys that are failing and the patient is not so healthy, and the kidneys then attempt to hypertrophy to improve their function, all they end up doing is getting bigger. It does not help with functionality at all. So, as I mentioned before, hyperkalemia is the most life-threatening effect of renal failure. And that is because, as we know, potassium has a very short window of happiness, 3.5 to 5 in the serum. If it exceeds that, then we start courting things like, arrhythmias, and then they can be really bad arrhythmias. Your normal kidneys excrete your excess potassium, so you never have to worry about this. Your kidneys help you void it out, and then you're done. But when your kidneys are failing, they don't do that. They retain that potassium. The problem is we can't just use a little potassium vacuum cleaner and go in and get the excess out. We have to find a way to get the potassium out of the body, and it's not easy. We have two options that we can use. One is better than the other, but the first is, this is a conservative treatment, but the first is to give IV insulin and glucose. Why do we give insulin and glucose? Well, we give insulin because we want glucose to go into the cell. If you recall, glucose stays in your bloodstream normally, and it requires the help of insulin to get into the body cell so that the cytoplasm can break it down in the first part of glycolysis, and then it can be put into the mitochondria to finish metabolism. But it's got to get in there to do that. Well, the nice little side benefit of glucose going into the cell is whenever glucose goes in the cell, potassium kind of acts like glucose is the big brother and it's the little baby sister that wants to follow the big brother everywhere. So when glucose goes into the cell, potassium follows. Potassium is an intracellular ion. So if we can get potassium into the cell, we get it out of the serum where it's potentially causing life-threatening arrhythmias, and there's really no limit to how much we can put in the cell. But the problem is it won't stay there forever either. So we have to do more than just get it into the cell. We'll talk about that in a minute. Now I want to go back to the other way that we can get it into the cell. Bicarb. Sodium bicarb is a base. So if you think about your vasculature and your cells, they're right next to each other. If I give that patient a base in their vasculature, in their vessel, the body is going to want to neutralize that base. So what will happen is hydrogen ions, which are considered free acids, will come out of the cell to neutralize that bicarb so we don't make our patient go alkalotic. It's a +1 ion that likes to be inside the cell normally. Well, another +1 ion that likes to be inside the cell normally is potassium. To keep everything balanced, when the hydrogen ions come out to neutralize the bicarb, potassium ions go in to replace them. So that's another way to sneak potassium into the cell. However, complicating factor for renal failure is that our patients are already in metabolic acidosis. So there's already a lot of free acid, so it would take a lot of bicarb to even have an effect. Insulin and glucose is a much better, more efficient, and safer option, so that's usually what we use. Okay, so we got potassium in the cell. Now what do we do with it? Well, we give another drug, PO by mouth or PR per rectum, called Kxalate. Kxalate is a fantastic drug that basically siphons the potassium from the cell and pulls it into the lumen of the bowel. How does it do this? I have no idea, but I know it does it. It pulls the potassium into the lumen of the bowel, and then when the patient has a stool, then obviously the potassium exits. It's one of the reasons they like to use Kxalate enemas, because not only do you pull that potassium down in there, but you get the immediate excretion of it, because enemas usually end up with a bowel movement at the end of it. All of these things I've mentioned are conservative ways to try to treat potassium, especially in acute renal failure when you don't necessarily want to put the patient on dialysis. But these have limited efficiency, and so if the patient's potassium level is really high, or if they're a chronic renal failure patient, more than likely their potassium level is going to have to be managed by a dialysis. So I've put some of the signs and symptoms that you would see in hyperkalemia on the slide. You can look over those, of course, but there's a reason that arrhythmias are first, because hyperkalemia can cause fatal arrhythmias. Now let's talk calcium. Patients who are in renal failure are hypocalcemic. This is actually because of several things. The first is you need vitamin D to absorb calcium from the gut. You just won't do it. You won't absorb calcium unless you have vitamin D. Well, kidneys, normal kidneys, produce vitamin D. But as you can imagine, in renal failure, they don't do that. So you have a poor calcium absorption from the gut when the patient's in renal failure. Then, we've already mentioned that kidneys kind of go backwards, and calcium that it should be reabsorbing if it needs it is now being excreted. And that calcium excretion also lowers the calcium level, but wait, there's more. Remember that everyone who has a hypocalcemic situation also has a hyperphosphatemic situation. And the problem with that is when we just try to cure this by giving additional calcium, either by way of we giving it or the body pulling it from the bone, which we'll talk about in a moment, the problem that happens is when you add calcium to that phosphate, it is very happy to combine with the calcium. So then you get calcium phosphate salts, which should normally be bone salts, but instead of going back in the bone, it's excreted out the skin in the form of something called uremic frost. Uremic frost looks like a film, and it is a gritty film that's on the skin. You'll see it a lot in the skin folds too, but it's all over the skin, and it's got the consistency of sandpaper. So it doesn't take, it's itchy. So when the patient starts to scratch or itch it, and it's sandpaper-like, you can probably imagine that we're going to start having some skin integrity issues also. But back to the calcium, okay? So we are not absorbing it, we're excreting it in two ways, out the kidney and through the skin in uremic frost. The body will try to combat that by releasing parathormone from the parathyroid gland to pull calcium from the bone. However, since the phosphate is still elevated, all it's going to do is just feed more and more of that calcium phosphate, and then again, they're going to have more and more uremic frost. So at this point, you do need to commit normal calcium levels to memory. In Southwest Missouri, 8.5 to 10.5 milligrams per deciliter is our normal range. Now, I went ahead and put the milliequivalents on there just so you could see, because, you know, when we're talking about sodium and potassium, they're measured the same way. So you can compare apples to apples, meaning for every 135 to 145 sodiums that are in your bloodstream, there should be 3.5 to 5 potassiums, far fewer. So if you want to get an idea of how much calcium you need, you need 4.5 to 5.5 milliequivalents of calcium. So a little bit more than potassium, okay, but still way less than sodium. That's so you can get it in your head and compare apples to apples. But no one here measures it that way. When you see lab results, you're going to see 8.5 to 10.5, okay? The signs and symptoms of hypocalcemia, the little song I taught you, twitch, twitch, seize, seize, Shabastic Centrosos, well, that's because the twitching and the seizing happen because that lack of calcium causes the muscles to be irritable and kind of do some rapid random firing. There's where you get your twitching, which can lead to seizures. If you're tapping over the facial nerve, you'll see it demonstrated through Shabastic sign, which is where the side of the face kind of all cramps up. And then trousseau is when you put the blood pressure cuff on the patient and you're pumping it up, the arm will flex, and it'll kind of flex and it'll shake when it's flexing. The problem with hypocalcemia, as I mentioned on the previous slide, you cannot just give them more calcium. So we have to first lower the phosphate and then give calcium and vitamin D. Well, handily enough, there is a drug called, wait for it, Foslo. And Foslo actually helps to lower the phosphate level. So most renal patients are going to be taking that every day, maybe a couple of times a day, just to maintain and try to keep their phosphorus level low enough. But you still have to follow that up with calcium and vitamin D.